when we speak of elevated cholesterol and when you have a cholesterol profile, generally we're looking at three main components: the LDL, or low density lipoprotein, which is the small cholesterol particles that will get into the wall of the blood vessel, and we always say L is for lousy. The second is the HDL, or the good cholesterol, which acts as a scavenger, which helps to prevent the LDL cholesterol getting into the lining of blood vessels. And we usually call that a healthy cholesterol, H for healthy. And the next is triglycerides. Triglycerides are the light fat. When you boil meat, rises to the top. And that we have from increased sugars and carbohydrates in the diet. Triglycerides affect the function of the HDL, so they do not work efficiently in clearing the LDL particles. A normal coronary artery, where the walls are very thin, and if you were to cut it like a tomato, you would have just a smooth, this is the area of blood flow. Well, this blood vessel has plaques. That's a buildup of cholesterol, the yellow streaks you see in the wall of the blood vessels. And so when you do a cross-section of that, you can see you have the plaques here, which blocks the artery. The hole is down. So that's why we call this hardening of the artery, because sometimes you will have, or in cases, you will have calcium within the plaque. So that's a common term when persons would say, I have hardening of the arteries. The other is when persons say, I have a blockage. This is what they refer to, the obstruction of blood flow because of the plaques. And so that's a problem with elevated cholesterol. It gets into the wall of the artery, and this process begins very early actually begins in adolescence. So basically we'll come back to that, but that's just an idea of when we see persons have plaques. As some persons at the health fair had plaques within the carotid arteries, and that was the meaning. Now, we have certain groups of patients who should be on medications for high cholesterol, regardless of what their cholesterol is. And we sort of run into that problem when persons say, oh, I was taking this pill and my cholesterol was good, and so I stopped. But basically, these are high-risk patients who, regardless of the LDL, whether it's 140 or whether it's 90, they need to be on a statin. We'll get furthermore into statins. These are patients who are diagnosed with coronary artery disease, or they have poor circulation, vascular disease. They should be on a statin. And if they are less than 75 years old, we usually say a high-dose statin. More than 75 years old, we can cut the doses back. If persons who are diabetic between the ages of 40 and 75 should be treated for cholesterol, regardless of what their cholesterol level is. If someone presents and they have an LDL, that's the lousy cholesterol, which is more than 190. I saw one such person at the health screening. They should be on cholesterol. That tends to be familial. And also, nowadays we have what we calculate estimated risk. The risk of someone having a heart attack or stroke in the next 10 years. And we have that on our phones. It's an app. We have that on the computer. And one just has to plug in age, sex, whether they're diabetic or not, smoking. And you need to know what is the HDL cholesterol, and the total cholesterol, and what is their blood pressure. And that was what was being done at the health fair. From that, you can calculate the risk. Now, as we get older, we're all at risk, so age is going to go up, and that's going to put persons at risk. So a lot of persons will have a risk somewhere around greater than 7.5%. That would qualify to be treated regardless of what your levels are. However, the problem which I ran into in Colorado Springs, which the population there was very active. They exercised 5 days per week, they hike, they ski. So it was a very active population. And they would come in at about 7.58, and they would be reluctant to actually take a statin. So we would do what's called a calcium scoring study, which is done at this hospital also, in which you do a CAT scan and you look for calcium within the wall of the blood vessel. If you have calcium in the wall of the blood vessel, that's one of the earliest signs that one is at risk. And that can go a score from 0 to 1,000 or more. Generally, the latest recommendation is if your score is not 0, you should be treated for high cholesterol, getting your LDL cholesterol to 70 or less. So the patients who have these conditions, they've had a heart attack, stroke, stent, cabbage, diabetic, if their bad cholesterol is greater than 190, or if their calculated risk is greater than 7.5. Regardless of the cholesterol level, they should be on a statin. This statin drugs, how they work, they're anti-inflammatory. So they not only work by reducing your cholesterol, they also work at the level of the lining of the blood vessel to reduce the LDL getting into your blood vessel. And so they reduce stroke risk. So anyone who has had a stroke who comes into the hospital, they automatically get put on atorvastatin. So they don't measure their cholesterol or anything, that's the treatment now. And they also reduce myocardial infarctions in persons who have a strong family history. But we have several statins. We have Crestor, which I'll go by the names that's shorter. Crestor, a lot of persons here take Lipitor, Zocor, and Pravachol. Those are the most popular statins. The Crestor is the one that has less muscular side effect. However, and it is also the most potent getting your cholesterol down. The Lipitor, the advantage of Lipitor, it acts on the triglycerides also. It's not as potent as Crestor, but it's better than Zocor. The Zocor is the cheapest simvastatin. A lot of the insurance companies always pay for that one. But the problem is you can't take it with certain blood pressure pills. So there's some interaction, and also with grapefruit juice, so there'll be interaction there. The Pravachol is one of the weakest in terms of getting your cholesterol down. However, it has the least effects on your muscles for persons who cannot tolerate a statin because they have muscle aches even after reducing the dose. They should have a trial of the pravastatin. Now, the diet. I know some patients at the health fair brought up the Mediterranean diet, which has gotten a lot of, which has been in the news for the last couple of years, because they're found that persons who are the Mediterranean diet tend to live longer and not have as much cardiovascular disease. And the Mediterranean diet is simply red meat, not more than twice per month, fish at least twice per week, and vegetables, substituting olive oil, and also nuts. So that's the Mediterranean diets, which some persons have tried, and I've also said another way of looking at it, the rule of thumb I always say is 10 vegetarian meals per week. If you have 10 meals that meatless, cheeseless, and eggless, then that will help to reduce your cholesterol. And reducing sugars, that's sort of the latest fad now, is reduction in sugars to reduce your triglyceride, and intermittent fasting. Those are all the fads there. And smoking cessation will increase the HDL cholesterol. I would mention I saw a few patients at the health fair, and they said, well, we're pre-diabetic. And exactly what that refers to is the metabolic syndrome is a term for that. And patients who have the metabolic syndrome are at a high risk of becoming diabetics if they do not change their lifestyle. And these we want to have 3 of these 5. Waist circumference, we do a cholesterol profile to look at the triglyceride HDL. We look at the blood pressure and also fasting blood glucose, like what they were doing at the health fair. So that's the pre-diabetic. Now the thing about pre-diabetic, a lot of patients will just say, oh, pre-diabetic, I'll go on metformin. And that's a part of the treatment. It's going to be diet, weight loss, because if persons put on weight, you increase insulin resistance, so you have the required amount of insulin just as you're resistant. And therefore, you will develop diabetes if you have the metabolic syndrome. Exercise also helps with weight loss. The treatment is metformin or lifestyle modification. Metformin, a lot of persons are on metformin, that's sort of automatic, but as I've always said, lifestyle modification is the most effective means of reducing the risk of diabetes if you have the metabolic syndrome or prediabetes, meaning they have done the studies and they have looked at persons who were on metformin and persons who went to diet, exercise, weight loss. The persons who did the first, they did better in the number that went on to develop diabetes. So, you know, it's good, the metformin, but metformin should not, it's not the be all and end all. I think we'd rather to persons to do the hard work. As Cindy Crawford always said, it's hard work, diet, weight loss, and exercise. And hypertension, as you all know, but we saw quite a number of persons at the health fair. They would have elevated blood pressures. We usually define high blood pressure as more than 140/90, and this is on 2 separate occasions at least coming to the physician's office. And recently, this has been decreased. The level now is 130/80. So, severe hypertension greater than 160/100. I saw a couple of patients at the last health fair, and they said, well, we have the white coat syndrome. And yes, you can have high blood pressures in a physician's office, and that is why monitoring blood pressures at home is the way to diagnose this, or a 24-hour blood pressure monitoring device, which I'm trying to get here. I think we need to get to that. Also, what persons don't speak about is what's called masked hypertension. And I've seen a few patients like that. They'll come into the office and their blood pressure is normal, but when they go home, their blood pressure is high. And so that does not get as much play as the white coat syndrome, but that is also the reason for home monitoring. And then we have persons with orthostatic hypertension, which we see when persons stand up, their blood pressure shoots up and they get dizzy. But the main thing is that we need to have home monitoring of blood pressure. And when one gets a device to monitor at home, you should validate the device, meaning you should take it into the physician's office and have it checked against the manual reading. The home oscillatory blood pressure monitors tend to be higher than the manual, and that's just because of how it monitors blood pressure, how it measures the blood pressure. So you have to know, when I subtract 10 from the top, and that will be more accurate. Also, you should measure blood pressure at different times of the day. Blood pressure tends to be higher in the mornings, and that is why the latest trend was for persons to take one of their blood pressure pills at night, so that would be working in the mornings when they get up before the morning dose actually kicked in. And then the correct way to take your blood pressure. Now this is what, really, well, first of all, one should be sitting in a comfortable chair with the back supported. Empty the bladder immediately before. One should have their feet on the ground, rest the arm on a table at chest height, but if one is using a wrist cuff, that cuff should be placed at the level of the heart here. Do not talk while your blood pressure is being monitored. And one should actually sit for 20 minutes and measure your blood pressure intermittently, averaging all those. So that's the correct way to do it.